Welcome to another episode of the Wealthy Podcast. I'm your host, Shauna Nairos, and today is going to be a big episode for me. So if you are listening to this episode on the day we post it, this week marks the 6th anniversary of my breast cancer diagnosis. 6 years, the biggest health challenge I've ever faced in my life. As I've shared before, in late 2018, I discovered a small lump in my right breast, which I thought was nothing, and then it turned out to be something. Well, the first part of my journey, I met Dr. Kluftinger, who happened to be my surgeon, and he was the one who really demystified everything that was going to happen after I received the initial diagnosis. If you or someone you love is navigating an early breast cancer diagnosis, this is the episode for you. Well, today is going to be a big episode for me. If you are listening to this episode on the day we post it, this week marks the 6th anniversary of the biggest health challenge I've ever faced in my life. As I've shared before, in late 2018, I discovered a tiny lump in my right breast, which I thought was nothing, and it turns out it was something. I was diagnosed with invasive lobular carcinoma, breast cancer, on February 27th, 2019. Yeah, so almost 6 years. So I'm a mix of excited and a little emotional as I introduce you to our guest today, Dr. Andy, as he is well known, Kluftinger, who is a general surgeon here at KGH, but he also happens to be my surgeon. I've only ever had one surgery in my life. Dr. Kluftinger was the first person to really outline what might take place in terms of treatment on my cancer journey. He doesn't know this, but he was also the person who delivered the best news I've ever heard in my life. And he's helped me sort through some really, really tough decisions, all with the calming, compassionate patience and grace that he is so well known for. There is so much to being a surgeon, much more than you might think. So it is an honor to welcome Dr. Andy Kluftinger to the Wealthy Podcast.
Well, thank you. Thanks for having me. It's great to be here, and it's so great to see you so well, and can't believe it's been 6 years.
I know, it has been. Yeah.
It's awesome.
Yeah.
And thank you for doing all this work. This is fabulous for patients, for the public, and for the foundation. So yeah. Happy to be here.
Well, I'm super happy to have you. And you are a little bit of a legend in the surgical community, especially here. No, not because you're old, but because you're awesome. And I had the opportunity to choose my surgeon, and I had heard so many good things about, may I call you Andy?
Yes, absolutely.
Okay. I had heard so many good things about you that I was like, okay, I'm gonna go with Andy, and I'm so grateful that I did. Thank you for coming and for stepping out of your comfort zone. I didn't have to twist your arm to be here, but
She did not.
I know that it's,
No, always happy to help the foundation, and always happy to talk about surgery and breast cancer or anything else you want to chat about. Yeah.
Well, we're going to chat about all of it. So this podcast is called Wealthy.
Right.
And it's sort of like a play on health is wealth, sure right? Is. So I'm curious, everybody that ends up sitting in that hot seat comes with kind of like a passion or, a purpose that's really quite connected to health. Mm-hmm. And so I'm just curious, where did yours start? Do you have what inspired you to kind of get where you are? Tell me the story of little Andy. And
little Andy.
I want to be a blankety blank when I grow up.
I'd like to say I have some noble story where I found out my granddad or dad had cancer, and I was going to set out and cure cancer for the world. But there's no such thing. My granddad and my dad were butchers. Sausage makers.
Okay, so
I do know how the sausage is made.
Sure, yeah, okay. And, maybe you know how to cut things too.
Family has been in the meat business for a long time. So, but joking aside, I've always been a hands-on guy. I did shop in high school. I was in auto shop and woodwork and metalwork, But I did well academically too, so I thought medicine might be a fit for me. But then within medicine, I definitely wanted to do stuff with my hands, and so I ended up in surgery. And within surgery, I really like general surgery. So general surgery is really what used to be most of surgery, and then other things split off. So urology and obstetrics and gynecology and vascular and thoracic, they all kind of split off general surgery, but there's still a general surgeon who's as much a specialist as those others are. So, and I just had a passion for general surgery. I like the variety, and I like things that are hopefully easily fixable and quickly fixable. So sort of immediate gratification kind of stuff. You see a sick person in the emergency department and do an operation, and usually within a few days they're better, and it's very gratifying. So I love medicine, I love surgery, and I love being able to help people sort of with fairly straightforward procedures and events, and the variety that's general surgery.
So, so like it's very, we literally like whisked you off the surgical floor and brought you here. You're today. Still in your scrubs. What were you doing today?
Today was minor surgery clinic. So, I did fix some hernias and a couple of breast biopsies. Yeah. Breast cancer patient actually today. So, I do a ton of stuff. I do thyroid and parathyroid surgery, breast, GI stuff, colon, gallbladders, hernias, some upper GI stuff, fundoplication for reflux, a little bit of bariatrics. That's weight loss surgery. That's a bit of a special hobby of mine. And I just like doing the variety, and a bit of a dinosaur in that regard, and that a lot of the younger trained physicians or general surgeons tend to do subspecialty training. Right. I did a subspecialty kind of fellowship in laparoscopic surgery back in the early 90s. Okay. But I probably still have the most varied practice of my colleagues because I'm the oldest one now.
Wow. Well, that's a good distinction to have.
It is.
The wisest one.
I hope so.
Most experienced. So I'm going to jump kind of right into it, like where our paths intersect. And it's funny because like before we started recording, I absolutely love, a lot of people say, oh, I hate living in a small town, blah, blah, blah. And Kelowna isn't really a small town anymore, but it kind of is. And so our points of intersection are rarely just one. And you and I have some that are not just breast cancer, but that's kind of where I'd like to start with you. Because there are likely people listening to this podcast right now, just because of the stories that I've shared about my own experience, that are facing a cancer diagnosis themselves or walking alongside a loved one that may be facing a breast cancer diagnosis. So I kind of want to deconstruct a little bit what happens, because I was actually quite surprised that, I wasn't sort of like, as soon as, like, I was surprised at the process, I don't know if I just thought that you would magically be diagnosed from a scan. We talk about mammograms and all of that. But I was surprised that after I'd had the scan, that there was still some question as to whether or not I actually did have breast cancer. And so like you said, I had to have a biopsy, which was performed in medical imaging with a radiologist. And then after that, I was like, okay, do I get to go to the cancer clinic now? And that's not what happened in my case. And I actually don't think that my case was entirely unique in that way, in the sense that it was an early stage breast cancer that they could see anyway from the scans. So my first real sort of entry point was with you.
Yeah. And that's very common. Yeah. So that is very common. Breast cancer is still primarily a surgical disease. We definitely have additional treatments that are often required, and occasionally the chemotherapy and even sometimes the radiation comes up front. But traditionally, and I would say in 80% of my practice still, for breast cancer, the upfront treatment is biopsy, surgery, staging, and then typically some adjuvant treatment, additional treatment after surgery. So it's very common for the primary contact to be, well, medical imaging. If it's imaging detected, so screening mammography, then it often goes through medical imaging. And our radiologists are excellent at talking to patients about the findings and the likelihood. This is 95% likely that it's cancer based on the imaging, but you need a biopsy. So I'll often do the biopsy that day. Sometimes I have to bring them back. And then between the family physician and or the imaging physician, usually the next contact is the surgeon. And so we're kind of the quarterback at the beginning, and we put together the imaging, the biopsy, the clinical exam, the history, the family history. The radiologists, for example, aren't that party to the whole clinical setting. And then we decide, you and I together, or largely me, I guess, depending on what I know about it, whether it's upfront surgery, or if it's what we call neoadjuvant treatment. So adjuvant means in addition to surgery, and most adjuvant treatment historically has been given after surgery, whether it's radiation, chemotherapy, hormone therapy. But there are scenarios now, and more commonly than it used to be, where we do go neoadjuvant, which means the chemo or radiation comes up front and the surgery comes later. And so then we involve the oncologists. And it's a very common question I get in the office is, well, when am I seeing the oncologist?
Totally.
You're just the surgeon, but I need a cancer doctor.
Not
and
just the surgeon.
No,
but
it's
yeah,
true.
I know.
I'm the
yeah.
sausage maker. So, but we are generally the first contact, and we, in collaboration with our colleagues, decide on that sort of pathway. And there are cases where we're not sure, or there's differing opinions whether someone should have surgery up front or adjuvant therapy up front.
And is it usually if like the tumor is large?
Yes. So the more advanced the tumor, the more bang for the buck we get by treating the whole patient first with systemic therapy. Systemic means throughout the body. So that can be chemo, can be hormonal, can be immunotherapy. And it's a bit of a paradox in breast cancer. And a lot of women quite understandably think, well, the worse the cancer is, the more I need surgery tomorrow. Because
you just want to get it out.
You want this thing off your body. And the other paradox is that a lot of women think that the worse the cancer, the bigger the surgery I should have. And that used to be the thinking. So, I've been around this for 30 odd years. We used to do bigger operations for bigger tumors or large lymph node dissections, and radical mastectomy, which became modified radical, which became lumpectomy. So longer ago, we did bigger surgery, especially for bigger cancers. And we've learned through the years that the more locally advanced the tumor is, the more important it is to treat systemically first, to treat the whole patient with either chemo or other systemic therapy, and then do the surgery later when the tumor has shrunk.
Right. And that's what will happen, is it will typically shrink.
Neoadjuvant therapy has two advantages. It allows the tumor to shrink and may make surgery more feasible, less invasive, smaller resection, possibly a breast conserving operation that wasn't possible before the neoadjuvant. And the other thing we've learned is we then have a measure of whether that therapy is actually working. So if I give a woman, or our oncologists give a woman neoadjuvant therapy when the tumor is still in the breast, they can actually see how well it responds. Whereas the old post-op adjuvant therapy, we kind of gave it on speculation that there might still be some cells somewhere, but we don't really know if it's working because we don't see any more tumor. We've cut the tumor out, and now we're giving additional treatment to try and catch up any free cells, so to speak, but we don't really have a measurement of whether it's helping or not. Whereas neoadjuvant, we have a biologic system telling us that this chemo is or isn't working, and if it isn't, they can change it. So, and that's some of the changes that I've seen in the last 30 years for sure. Yeah,
and I, you mentioned that surgery is kind of like the primary intervention, is that what you call it, for most breast cancers. And again, if you haven't had cancer, I don't really think about these things, but as soon as you do, you're like, oh, okay. I think when you are facing all that horrible period of time at the beginning, and you probably get the patients at the worst time because there's no clarity on anything really yet, other than the fact that they have a breast cancer diagnosis. You don't know what stage it is. You don't know if it's spread. Like, all of those things are determined in surgery, right?
Correct, to a large degree. I mean, we do have imaging preoperatively, so we do know if it's spread
size,
to distant
maybe.
sites.
Yes.
But the general kind of ethos of breast surgery is removing the primary tumor, if possible with breast conservation, and staging the axilla. So the axilla are the lymph glands in the armpit, and we typically sample those at the time of surgery.
Yes.
So that's kind of the main treatment for most early stage breast cancers. And you're quite right. Until we get, even when we have a biopsy, we have limited information. We know, yes, it's cancer. We'll get some receptors now. We didn't used to get receptors just on biopsies. We used to have to wait for the permanent tissue, but we are getting receptors. But the final size of the tumor, the status of the lymph nodes, the true grade of the tumor, grade is how aggressive the cells look under the microscope. That all requires this main specimen, which is the tumor removed surgically. So a lot of the decisions that are made about whether you need radiation, whether you need chemo or hormone therapy or both, and for how long, isn't made until after the operation. And that's why most ladies see the surgeon first and the radiation and medical oncologists after that, when all that information is put together. And that takes time. And I share the frustration when you have all these questions in your head. What's going to happen, and who am I going to see, and how long it's going to take, and when do I start radiotherapy, and when does chemo start or end if I need it? And all I can tell you listeners is just be patient and let's get all that information, because it's so important to do it right and in the right order and to the right degree, that we don't want to rush it. And as much as instinctively you want to have surgery tomorrow and have this lump removed, it's got to be planned right, and it's got to be done with the right information.
Yeah, and I also think that choosing the right surgeon is really important. Because I remember at that time being, like you said, I was like, we just need to get this out. Like, you know, I mean, as a woman, you're pretty much like instilled with this terror of breast cancer from the time that you develop breasts. Like it's just in you. So when you do discover the lump and then come to confirm that it is breast cancer, it's like, okay, just you get it out. But I remember sitting with you. You were the first person that I was able to talk to about my breast cancer and what might happen with me on my breast cancer journey. What is that like for you? Because like you're like you said, you know, you're the family of the butchers and the sausage and all the things. Like, did they in like surgeon school, are they like, okay, so you're gonna have to sit with people that are like really freaking out, and like, so what's that like for you?
Well, I mean, it's always difficult in the sense that I empathize with every patient, but at the same time, it's what we do, right? And we do it so much and for so long, and we do it with other cancers. I treat colon cancer, I treat thyroid cancer. We see trauma patients, so you know, we're used to seeing distraught and worried patients and families, and you just got to take a deep breath and go through it step by step and listen to them and allay their fears and explain it. And I think most people, I don't want to say it's a blur, but I have a kind of a process that I go through in explaining things. And after doing it hundreds of, or perhaps 1,000 times, it becomes pretty standard. But it's totally understandable that it's very distressing to you, because you're the only time you're having breast cancer.
It's like a one-time thing, I hope. Yeah.
You don't want it ever again. And so is your family. And the other thing that's important with, well, all cancer treatment, but definitely breast cancer, is every journey is just a little different.
Yeah,
right?
I was going to ask you about that.
It's like saying I'm having soup for dinner, but there's so many soups and so many ingredients and so many factors, and that's breast cancer. So and everybody's heard stories, and they have a friend or a family member who had to have this and this and this, and then they wonder, why is that not what's happening to me? But it is a very individualized journey. A lot depends on the type of tumor, the stage, the grade, your age, your family history, your genetics. And what I've learned in the 30 years that I've been treating breast cancer is it's changed quite a bit, is it's much more individualized. We're making much more refined bowls of soup for each patient.
Totally.
Rather than the one size fits all that used to be mastectomy, maybe chemo, hormones. That was kind of it.
Yeah.
And things have definitely changed and improved, and we get much better outcomes when we individualize the care down to the molecular level now. So we're doing genetic and molecular tests that tell us your cancer is going to respond more to this drug than your neighbor's cancer, and so you're getting a different treatment.
So the good news really is that the prognosis, I guess, for most breast cancer patients is really good.
It is. It absolutely is. We cure a lot of breast cancer.
Yeah. Like, do you say that?
Absolutely.
Like, I'm really like, people ask me like, so are you cured? And I'm like really nervous to say that. But can we say that? Do we say that?
Well, we're always going for cure. So let me qualify that. There are scenarios where we know a cure is not likely.
Right.
Or perhaps even possible. And that's metastatic breast cancer. So we stage breast cancer based on size of the primary. That's the T stage. We have a TNM system. So we size the primary cancer. We assess the lymph nodes with imaging, clinical exam, and biopsy. And we look for, that's the N stage, and we look for metastases. That's the M stage. So T, N, and M together are condensed into stage 1, 2, 3, and 4. 1 is really good. 4 is really bad. And 4 is metastatic disease, and typically we don't cure women with metastatic breast cancer. That doesn't mean we can't treat them. We have lots of treatments, and we have lots of women who live long times with metastatic cancer, and some older women will live with cancer and die of something else.
Yes.
But we don't typically talk still about curing metastatic disease. But anything below stage 4 is curable, potentially. Now, we don't cure everyone, but we get many cures and we get many prolonged survivals. And that's how I approach a lady in the office. Unless she has metastatic disease, we're going for a cure.
Yeah.
But it's going to be a journey, and it's going to be surgery and most likely additional treatment. There are few women now that have surgery alone.
Okay, I was going to ask you that. Is that because I didn't, and I probably had, when you talk about your variety of soup, like mine wasn't the most common. Like I wasn't like tomato rice. No. I had it was a variant. So I have invasive lobular carcinoma, right, which is second most commonly diagnosed brand soup.
That's right. Brand soup.
And my particular, varietal was, you mentioned receptors, so estrogen and progesterone receptor positive. So. Right. Which is quite common. That's good. The rice in the soup, a lot of that. Right. And HER2 negative. So there's all of these little characteristics that are involved in your particular varietal brand of soup. And I wouldn't say mine was the most common. It was not uncommon. But it's rare that you would cure any kind of breast cancer with just surgery. Like I was a stage 1. So my T was a 1.
T1. Correct.
And what's an N?
N is lymph nodes.
Okay, so is it no?
And 0 if you have no lymph nodes.
But involved. I didn't know that going in.
Not until surgery. Correct. So
yes.
The lymph nodes are staged clinically with ultrasound or CT or MRI, and to some degree with physical exam. So if we feel obviously enlarged lymph nodes in a woman who has a proven breast cancer in the armpit on that side.
Like if you can feel it.
Correct.
Yeah.
Then they're usually cancerous. If you don't feel them, they still can be, and then we sample them In the old days, again, when I was early practice and residency, we did full axillary dissection. So that meant part of your surgery involved taking 15 to 20 lymph nodes out from under the arm.
Oh.
And if they were all clear, that was good news. But if they were all clear and we took them all out, we risked getting arm swelling and numbness in the arm and so on. So it was more overkill than we needed to do. And we've learned that through the years, that we can do a more targeted biopsy of the sentinel lymph nodes. So typically now we take out 3 or 4 lymph nodes and we find them with a special dye that we give before surgery. But until we put those under the microscope, we don't really know the lymph node status. So again, that's a scenario that you don't know going into surgery until you come out. And in fact, about a week after you come out, we get the pathology report. And so a woman's true stage is based on, again, that final analysis of the tumor in the breast and the sentinel lymph nodes.
Right.
And hopefully lack of any evidence of it in other organs based on the imaging before surgery.
They do all of that. Yes, they
so
do
all that.
Lots of scans.
But to get back to your question, who gets treated with just surgery? It's only the very earliest stages.
Yeah.
So in elderly women with a T1, less than 2 centimeter, just breast tumor, negative lymph nodes, we've learned that. So again, historically, when we did anything less than a mastectomy, if we did lumpectomy, we always gave radiation, which is pretty easy to take, but it's still another treatment after the surgery. Now we're finding some women don't have to have radiation. The recurrence rates are comparably low enough with or without radiation, especially if they're estrogen receptor positive, and they may get an anti-estrogen treatment on top of their surgery. But to get back to the question, the only true breast cancer that's treated with surgery alone is the T0, which is really the pre-invasive cancer, what we call carcinoma in situ. So DCIS, ductal carcinoma in situ, or lobular carcinoma in situ are sometimes treated with just surgery because it hasn't invaded the actual structure of the
tissue,
breast. So it can't go to the lymph nodes, it can't go to your other organs. And so if it's truly stage 0, then sometimes surgery alone is
sufficient.
Sufficient. Yeah.
Interesting. There's so many things. And I feel like this is so helpful, particularly if there are women listening that are in that early stage of like waiting for all of this information to come down the pipe. So when you perform, I'm sharing a lot here, but that's okay. I'm okay with it. Because I feel like it might be helpful to somebody else in the world, and that would just make it good enough for me. I had, on your recommendation, partial mastectomy or lumpectomy. And at the time, I just kind of was like, that's what you recommended. And I was like, great. That means that I don't have to have a mastectomy. Let's go.
Right.
What does that mean? Like, why would you recommend, like, when does that happen? Partial mastectomy, what is that? Or a lumpectomy? Why is that sort of like being recommended now as opposed to mastectomy?
Sure.
And when?
So one thing to get clear is lumpectomy, partial mastectomy, breast conserving surgery, they all mean the same thing. It means we're not removing the whole breast. We typically are not removing any skin or the nipple. Now, there's the odd scenario where we do a lumpectomy and we have to remove some or all of the nipple, which is, cosmetically not as nice, but we can still preserve the breast mound and the breast shape, and that's still a breast conserving procedure. That is still or nowadays, again, going back 30 years it isn't, but nowadays that is the commonest procedure. And lumpectomy or partial mastectomy coupled with radiation afterward is as good a treatment for that cancer as a mastectomy. So one of the first things I tell ladies in the office is if you're suitable for a partial mastectomy or breast conserving surgery and you're willing and able to have the radiation, which most women are, then there is no medical or oncological benefit from having a full mastectomy. It is not more curative. You're not more likely to see your kids graduate high school if you have a mastectomy over a lumpectomy and radiation.
And it's a major surgery.
It is a big surgery. It's very disfiguring. And it really doesn't cure any more ladies than a lumpectomy with radiation. Now, there are some exceptions. If there are more than one tumor in the breast, if there's a lot of DCIS, that pre-cancer change. And sometimes in women with a strong family history or genetic abnormality, we will lean towards mastectomy.
Right.
But mastectomy of that breast or a mastectomy on the other side, which a lot of young patients also come in asking about, like, should I just have them both off and be done with it, so to speak? And I spend a lot of time explaining that, yes, we can do that. And yes, it will prevent new cancers from forming in the next 50 years. And if that's what you're after, then that is an option. But again, it's not more likely to cure
the cancer you have,
the one you already have. So most of mastectomy on the affected side, and certainly mastectomy other side, is a preventative thing for a second cancer rather than a recurrence. And that's something many women don't understand, and rightly so. And they see in the media and on Facebook.
Totally.
You know, I'll just have them both off. It's the best treatment. And Angelina Jolie had it.
I know. I was going to ask you that, but you took care of that for me. Yeah.
And it's one of the paradoxes. The double mastectomy is actually better treatment in the early cancers or pre-cancer stages, or the woman who doesn't even have a cancer yet but has the genetic abnormality.
Right. And which is actually kind of, I don't want to say rare because I don't want to diminish that, but like, no. In terms of what we know, what causes breast cancer, and I know this is not your area of expertise, but for the most part, it's not genetics.
Correct.
Yeah.
And most women don't need a double mastectomy.
Yeah.
Even if they have a family history. So there's a lot of stuff that goes into genetic testing and counseling for women with some family history. I don't want to get into all that, but there are some select groups where there's history strong enough that we do the genetic test. And if the genetic test is positive for certain mutations, then the probability of them developing breast cancer in their remaining lifetime, it's never 100%.
It's higher.
30 or 40 or 50%. And with a good genetic counselor explaining the results and the probabilities, women can then decide, do I just keep screening carefully and deal with the cancer one day if it happens, or do I want that peace of mind and have a preventative or prophylactic mastectomy? But you're right, it's not that many. And it's one of the paradoxes that bigger surgery before the SHIT hits the fan makes more sense than when it's already happened. So I often see women that have a big cancer in the breast and several lymph nodes, and their risk of dying from the cancer is higher, and they're better served with chemotherapy sooner than later than a big surgery. And yet they come in thinking, well, I've got this bad cancer, I want to do everything I can, so just lop it all off.
Yeah.
And it's a misunderstanding that we often have to help them work through. We'll still do it if that's what they really want, or we can do it later. If they have their chemo and their radiation and we've cured, or we at least think we're very likely to have cured that cancer, and we're worried about prevention for the next 20 years, we can do the other mastectomy and reconstruction and the sort of complicated, prolonged stuff 6 months later, a year later, when the dust is settled and the cancer is gone. So it doesn't all have to be done right away.
And it's so amazing. You're so good at this too, and you're the person to talk to, because what I want to underscore here, and it's embedded in what you're saying, is that like women have the opportunity to make choices all the way through. It's not like you see on TV where the doctors are telling you exactly what you have to do. It's really consultative. Certainly you're an expert in this, so you provide recommendations, but like I had a lot of questions, and I even came back to you years later and was like, hey, can we just get rid of them? Because I'm terrified it's going to recur. And you really helped me sort of unpack that. And you were very good about saying, like, I'm not going to tell you what to do here. I'm just going to give you, like my expert opinion on what's going to happen and what your chances are. And that's what, like, I feel like sometimes people don't realize about general surgeons. Is that like it's more than just that's making the sausage? Yeah.
Absolutely, and it should be, and it's very consultative, and it's very much joint decision making. And my job is not to tell you what I would do or what my wife should do if she had, or well, I wouldn't tell her what to do either. Never got far with that. But even what I would advise my relative to do may not be what's right for you.
Totally.
So our role is to lay out the facts, the options, the probabilities, and a lot of breast cancer is probabilities. And that's tough too, right? If some people are betting people, if I say you have a 6% chance of this, if we do this treatment, and a 9% chance of that, what do you want? Some will say, well, and they can work that all out. And others say, well, I'm not a horse in a race. Just tell me what's best.
Yeah,
so,
totally.
But we lay it out and we explain it, and then it's a joint process where we come up with a plan. And you're right, it can be different for different women, and different risk tolerances are different between people. They're different at different times in your life. A 40-year-old woman with breast cancer is very different from an 80-year-old woman. They both have breast cancer. They both have biology that's going to dictate things, but your outlook on life is different at different stages in your life. So it's very individualized, and you're right, it has to be a joint effort. And I, my secretary books an hour for every breast cancer patient because it takes that long to go through that. And it's great to have your spouse with you, or your partner, or your parent or child, somebody else who can listen in.
Because you really only hear about 10%.
Yeah, I only hear the C word, and then you kind of tune out.
It's so true. Yeah.
And, I always say, call me in 2 days or a week or whatever, and we can talk about it again and revisit it all. So, it's one of the more complicated interview interaction diagnoses compared to some of the other stuff I do. If you have appendicitis, we kind of take your appendix out.
Totally.
Move on.
But you're right. Like as a woman that went through it in my 40s, I was thinking about a lot of things. Right. There's a lot of, and I've had other guests on this podcast, and we've talked about sort of the psychological and the emotional impact of going through that journey and that diagnosis, and what it means to be a woman, and all of these things, right? And it's all like circling around like a running program in the back of your head, and you're trying to listen, and it can be a lot. So
it is a lot.
So let's fast forward. We've chosen the surgery, we're proceeding, we move ahead. And then it's all done. What are you looking for? Like, I remember this was really it was like, I knew you were what we were looking to get out of that surgery to make sure it was the only surgery I had to have. So what are we looking to achieve with that?
Sure. So in most early breast cancers that can be treated with breast conserving surgery, we look to remove all of the cancer with what we call a clear margin.
Yes,
and that's the
margin.
Edges around the tumor. And we used to say they had to be a certain amount of millimeters. We've learned again over time that as long as there's no cancer cells at the margin, what we call tumor on ink. So we paint the specimen with ink and send it to the pathologist paints it, and then they make slices. And if they see cancer cells going right up to the inked margin, then that's a positive margin, and that's not great. That means we should go back and take a little bit more.
Yeah.
But if we get 5 millimeter margin or 2 millimeter margin or anything more than that, then that's fine.
Yeah.
That's all we need. And so we balance, the desire to get clear margins with not taking more than we have to.
Yeah.
Because our other desire is in breast conserving surgeries to achieve a cosmetically acceptable result. And that obviously depends on the size of the breast, the location of the tumor, and the size of the tumor. So a good outcome is a clear margin with a good cosmetic result. And so that's, what all surgeons want, and obviously all women want. And then we need a representative staging of the axilla. So that's typically a sentinel lymph node biopsy. So we look that the lymph nodes take up the dye that we use to find them. The fact that the lymph nodes take up the dye doesn't mean they have cancer in them, but it tells us those are the lymph nodes we want to look at. So if we get a successful,
you want them to light up.
They light up.
Yeah,
so you get a dye in the X-ray department that's radio traceable, and then the blue dye that we inject in the operating room. And between those two, we find the representative lymph nodes in the armpit. And if it's a successful axillary biopsy, that means we get 3 or 4 sentinel nodes. And then obviously it's nice when those are not involved, because if they're
it's
not
not
involved,
just nice, it is like
huge.
the best.
Absolutely.
Yeah.
But it's not a death sentence if they are.
I
That's
know.
the other thing I tell my patients is, we're going to look at the lymph nodes. If none of them are involved, that's a good thing. If 1 or 2 are involved, if it's microscopic, it's not as good. But again, in the older days, it was lymph nodes involved, chemo, lymph nodes clear, no chemo. It's not that simple anymore.
Right. Yeah.
So we look at other factors. We look at the size of the tumor. We look at the hormone receptors, the HER2 receptor, and to some degree now the genetics of the tumor. Not your genetics, but the genetic and molecular characteristics of the tumor. And that's the oncogene test that's sometimes sent out to California. And our oncologists will put all that together and then meet with the patient and discuss the adjuvant treatments after. So to get back to your question, what I'm looking for and what my role is early on is to get the cancer out of the breast, hopefully leave a cosmetically acceptable breast, and that's a variable thing among patients too, and have clear margins and have a good axillary dissection without causing too much damage in the axilla, which is the old full dissection caused lymphedema, which is swelling of the arm, sometimes numbness, sometimes fluid collection. So we want to do the most good with the least harm.
Mm-hmm.
And when that's happened and everything is healing and the pathology reports are back, then I start to step back because I've done the surgery. We don't go back for positive nodes. If there's just 1 or 2, we've learned that taking more nodes out isn't going to cure you more. We're going to do chemo anyways. We will go back for positive margins. So if the margins are positive, then I have to phone you and say, I'm sorry. And it's not something I did right or wrong. You can't see cancer cells with a bare eye.
Yeah.
We do the best we can at the time to go around it. And sometimes we have a positive margin. I warn everybody that's possible. It's only about 6 to 8% of the time.
Mm-hmm.
And it's not the end of the world. It just means you have a second operation, another anesthetic, and taking a bit more of the breast tissue. But when all that's clear and all of it's packaged together, that's when we send all that information and the patient to the oncologists.
Mm-hmm.
And then it's typically radiotherapy for the breast if it's been a lumpectomy, and maybe some systemic therapy depending on all those factors that are in that bowl of soup.
The ingredients. Yeah. Okay. So a couple things. Mr. Nairos would like to thank you for doing such a lovely job. Of all of your work was very well done. We can leave it at that. Yes. And also the best call. I mean, I've had 2 children, and that was definitely a moment I'll never forget, is meeting my children for the first time. But I was like really sweaty and uncomfortable. And the call that I got from you, I'm going to share, I was driving. You probably don't know this when you what happens with your patients. Now you're getting the whole backstory. I was driving to the Energy Plex.
Okay.
I don't even know if that still exists, but it's like this place where little kids go and play.
Oh, yeah.
And so I dropped my kid off there, my son Jack, and he was playing with his friends, and I was going to pick him up because that's what you do. Also, when you have breast cancer diagnosis, is like you're not really in the hospital, like you're still out living your life. And so I was. And the other good thing is that, my surgical experience, I went in very healthy as I possibly could. And so the recovery was quite insignificant. Like I was sort of up and about and doing, not, obviously I wasn't doing yoga and all of that, but I was moving around and doing pretty good. So I was picking Jack up from the Energy Plex, and the call came in, and I saw that it was you, and you said, "Hi, it's Andy Kluftinger, and I just wanted to call and let you know that the margins are clear and there's no spread to the lymph nodes. And I literally I hung up the phone and I rolled down all the windows in my car and I just was like, yes, that was really good news.
That is awesome news. And I love making those calls.
Yeah, I'm sure you do.
Because they're not always like that.
Yeah, I know.
But even when they aren't, that's the other thing. And I try to prepare patients beforehand. I said, if it's in some of the lymph nodes, it's not a death sentence, not incurable. If the margins are positive, we can go back and take some more. Mm-hmm. So it's not all doom and gloom if those things aren't happening. But yeah, those are nice calls to make, and I'm sure they're very nice to receive.
It was wonderful because it sort of capped off a really stressful. I mean, there was still more to come, as you've said. Mm-hmm. It doesn't end there, and I did end up referred to the cancer agency, and I had my radiation therapy, and I love all of those people over there.
They're awesome.
Had my radiation therapy at the beach, and so anybody that's had radiation therapy knows what the beach is. It's not the kind of beach you'd think it is, but it's not totally awful. No. So much love for all those folks over there.
Yeah, no, they're terrific. And the other thing you mentioned, finding the right surgeon and finding the right treatment. The beauty of healthcare in Canada is it's very good and standardized. Mm-hmm. You don't have to worry about going to the Mayo Clinic or finding some private exotic place to treat you. You are going to get state-of-the-art standardized care from a good general surgeon anywhere in the country, from a qualified radiation oncologist, from a qualified medical oncologist. They're following internationally recognized protocols, the latest literature. You're going to get the same treatment in Kelowna as in Toronto or Vancouver or Calgary. It's very reassuring, and it's so nice for patients, and it's even nice for me to say, look, you go over there, you're going to get taken care of, and it's going to be the right thing for you. Mm-hmm. We don't have private cancer clinics, and I mean, there's stuff out there, and listeners should be aware that don't go down the rabbit hole of bogus cures. But if you're being looked after by one of the hospital affiliated cancer clinics, you're going to get the right treatment at the right dose by the right people, and you don't have to worry about it. You don't have to run around. That doesn't mean you shouldn't be informed, but you don't have to fact check and worry about that. That's going to be good care.
And I can say firsthand, I have experienced that myself. And it's why, I'm going to do, obviously we're here, KGH Foundation, we've been in a campaign for the last almost a year now to raise funds for surgical oncology, specifically for cancer, but not just breast cancer, all the cancers, because there's always evolving technologies. There's research that can be done. There's new interventions that just kind of, like you mentioned, lymphedema and some of the diagnostic tools that we use. There's always new technologies that are out there. And I would just like to say thank you to our donors, because they get behind that, and they're really ready to work with us, and we work with you guys, you and your colleagues, to really try to make sure that standard of care, that world-class care, is available right here at KGH. So it really is, it is amazing. The people that work in the system are, we know that there's challenges in the system in Canada. We know that, but there's the people that work in the system are incredible, and that certainly was my experience.
Yeah, no, I'm glad to hear it. I totally feel the same way, and I have, no hesitation having any of my family members treated in Kelowna for just about everything we do here. I mean, it's the best, it's the biggest little hospital in the country, right? We're actually probably one of the only hospitals that's small enough to have everything in one place, but big enough to do all that we do. And
can I steal that? The biggest little hospital in Canada.
Yeah, that's true.
Sounds like a marketing line.
That's right.
Oh, okay.
And it pays off in so many ways. Like I've had patients sent to Vancouver for something unique, but when they get there, that hospital does that, but they don't have everything else. If they run into something unexpected and they need a urologist, they got to come from Vancouver General because they don't have them in Women's Hospital, or they don't have pediatricians at any of the hospitals except the Children's Hospital.
Totally.
And so if you're going to be sick or in a car accident or your whole family needs treatment, KGH is one of the best.
This is it. Yeah. The other thing is that, you know, we also live in the biggest little city in Canada. So, you know, like you were neighbors with my parents, and one of your colleagues' wives is, you know, on the grad committee with me, you know, like I do believe that is such a beautiful thing about what we provide at KGH and in this community, is that it is local, that you actually you do know your healthcare providers because they're your neighbors, your friends, your, you know, brothers, uncles, cousins, buddy, squash buddy, like, you know, and I do think that makes a difference.
Yeah. And it's a lot of fun to practice in that.
Yeah.
Right. I know, you know, pretty much all the surgeons. I know, all the specialists really. And I've been here long enough that I usually can pick someone out at the grocery store.
Totally. Or you can't hide in the grocery store.
Right. No, not too much. But that's nice too.
I know. I really appreciate it. Yeah. I'm getting like, can you believe how quickly this has gone by?
Yeah, it's going fast.
I know. I don't even know if I've gotten
questions?
all of my questions. I think we probably have. Probably could have you back. But I kind of want to switch gears a little bit, because this podcast is called Wealthy. We think we're very clever in that name,
cool.
But really what we're getting at is that our picture of health is multifaceted, and it's not just physical or emotional or spiritual or mental. It's all of those things, financial, community, all of these things make up our wealth as human beings, right? And we've had a really great opportunity today to talk about a really specific health challenge that many women are facing these days. The good news that you've shared is that it's largely curable. And I think we can safely say that. But I'm curious, for you, you know, being the wisest general surgeon at KGH.
I wouldn't go that far. You said oldest, not wisest.
What has changed for you over the years in terms of what your definition of health is in general?
Definition of health?
Yeah.
Well, it's a lot of what you said. I mean, there's no question, you know, and I'm a surgeon. I cut stuff out and sew stuff up and stop bleeding and put plugs in holes, but it's not that simple, that's for sure.
Yeah.
It's everything. And I've definitely learned that, you know, the patients who do the best are the ones who come in healthy, you know, unless they're with an illness, but their background health is good. So
right.
Take care of yourself, nutrition, not smoking, not drinking excess alcohol, watching your weight. Those things are huge. And any given disease at the same stage, the same severity, will do much better in the otherwise healthy patient. So when patients have comorbidities, they come in with diabetes and obesity, and, you know, and some things aren't modifiable, but many are.
Right. We're learning a lot about that.
Sure.
Yeah.
They don't do as well. So absolutely, we want to be as healthy as we can in our everyday lives. Fresh air, exercise, mental health, family health. Financial wealth is nice, but it's not achievable for everybody. But just having your life in order and less stressful and supported by people around you is so useful and so helpful for when something like this does happen.
When the SHIT hits the fan.
Exactly.
Because it will.
Yeah, we absolutely will. And
yeah.
So that's, I've always felt that, and definitely I've learned it more over the years. What else can I say? I should talk a little bit about misinformation and the internet. And
I would
Dr.
love
Google.
that. Yeah.
Yeah,
Can we talk about
Sure.
that?
Well, it's a bit of a pet peeve. Well, not a pet peeve, but I certainly in the last 10 years have battled more bad information, misinformation, outright, fraudulent stuff. And I just want listeners to still have faith in this. We've had a loss of expertise. People they listen to Facebook and Dr. Google more than their physician or their surgeon or their oncologist. And it's not to say you shouldn't get informed, but please go out and get legitimate, credible information from cancer societies, university websites, consensus statements, National Institutes of Health. South of the border, they're cutting funding to the biggest national health organizations because of fake news, and I don't know what's going on there. But these are people and systems that have been in place for many years. They're experts. They do consensus statements that, given all the parameters and all the things that are out there, this is our best evidence of our best treatment. That's what you need to follow. There's nothing wrong with adjunctive treatments. If you want to improve your nutrition and take more vitamins and get more fresh air and do all the other things while you're being treated for your cancer, that's awesome.
Mm-hmm.
But alternative treatments where people think they can have a cure with an herb or a unproven machine or a unproven treatment in another country, please don't do that. It doesn't work. If it did, we'd all be behind it and we wouldn't be here doing fundraising for more research, for more credible stuff. There isn't some conspiracy or collusion that we're hiding the cure for cancer. I don't get checks from Big Pharma. I wish I did, but we're doing the best with the best evidence we have, and that is your best chance of getting a cure for your cancer or your other diseases. Mm-hmm. So there's my plug.
I love that. And I appreciate you saying that, because I think that it's really, especially when you're navigating this personally, you get sucked in. The first thing you do is go to the Google. And I will say, I will give Google a little bit of credit. There's a lot of information.
Awesome stuff.
And
Absolutely.
and if you know what you're looking for, the right sources, good information.
Absolutely.
But there's also a lot of really sketchy information, and people who don't have the same level of, like, it took you a really long time to acquire a medical degree and then 30 years of practicing medicine to have the level of expertise that you have. I like to think that I'm an expert on breast cancer because I had it, but I'm not. Right? So.
You're right. But you've learned a lot, and you're quite right. There's lots of good information, and being informed and having, before you go to meet your surgeon or your oncologist, having questions ready, having read some credible sites and what might happen and what might decide what treatment I'm going to have is very useful. And we're never offended or upset when a well-informed patient asks very legitimate, even if they're not necessarily pertinent questions, but they usually are, but that doesn't upset someone. Mm-hmm. But if people come in and say, well, I've read that this herb from this place in this country is the cure for breast cancer, why can't you get it for me? It derails us, and it gets us off the track and off the important work that we have to do and the goal that we have to achieve. Yeah. Mm-hmm. So it's just a plug.
Mm-hmm. I think there's a really great place, like you sort of mentioned it, like one of the, primary messages that we're trying to convey through this podcast is, we're giving people greater access to medical specialists and healthcare specialists, but at the same time, the opportunity to empower themselves to take some responsibility for their own health journeys, right? Absolutely. So like you said, you can do the research, you can kind of like look things up, be prepared when you meet with your surgeon, have questions, because I can guarantee they're going to all like write them down because they're all going to fly out of your head. Mm-hmm. and ask those questions. For me, I really appreciated being able to take responsibility for what I was putting in my mouth during my treatment. So eating really healthy and clean, not drinking alcohol. Like, those were decisions that I made based on research that demonstrated that there was some benefit to those things. And it also made me feel like I had some modicum of control in the situation. And so I think that there's a balance to be had, is like, you want to be a participant in your treatment and recovery, but you also have to really trust and lean into the expertise of our medical system, which, at least in my experience for breast cancer, is second to none. It was really a positive experience. And it worked, because here I am 6 years later talking to my surgeon, putting him in the hot seat.
That's right.
So good. Okay. I have like one more question.
Fire away.
Okay. It's like more of a personal question.
Okay.
What areas of your life do you feel wealthy or abundant?
Oh my gosh. Well, I got to say family.
Yeah.
I have an amazing wife. We've been married 36 years. She helped me through a lot of the residency years and the low income days. I have 4 beautiful children, 4 son and daughter-in-laws, and 7 grandchildren. We just spent a weekend at Big White skiing, and just being with family, being outside, had some good meals and lots of fun. That's
the best medicine.
That's where I'm wealthy.
Yeah,
for sure.
Yeah. Sometimes we forget, right? Just the people and this beautiful place that we call home. We're so blessed, and a good meal, best medicine.
Can't beat it.
Okay. I have one more question, because I have 2 children that are of the age that they're making decisions about their futures. If a young person were to come to you and say, I want to get into medicine, maybe general surgery, what would you say?
I say go for it if that's what you want to do. Yeah, I mean, we teach medical students every week. We have 32 local med students in 3rd year every year, and some of them are interested in general surgery, and some aren't. I think it's an awesome specialty. There's lots of variety. It's hard work. They're gonna have to get into medical school, get into a residency, put in a lot of hours. We do a lot of night work, a lot of weekend work.
You're not selling me.
I'm not selling you.
Andy.
So on
No,
lifestyle,
I'm kidding.
no. But
what are the rewards?
The rewards,
do you love?
as I mentioned earlier, we get to help people at their most critical time in their lives. The outcomes are generally good, and the results are usually visible pretty quickly, right? I mean, there's nothing like putting a few stitches in a perforated bowel or resecting a piece of disease, something or other, and seeing them 2 days, 3 days, or even a week later,
and like life-changing,
and they're better, and they're so grateful. Yeah, you get a nice bottle of wine and homemade butter tarts, and a donation to the KGH Foundation. That's the best payola for us, for sure. Awesome. Well, it has been a once in a lifetime opportunity to be able to have a full circle moment with you 6 years after my own diagnosis and cancer journey. So thank you so much for doing this and for sharing. It's been a great conversation. Thanks for having me. It's been great to come, and thank you for everything and for being so open about your own journey, because that's a very personal thing. But I'm sure it's helped a lot of women, and it's much appreciated. Thank you, Dr. Kluftinger. You.